첫 번째 연자는 우석대학교 한의과대학 장인수 교수입니다. 동대학의 학장과 병원장을 역임했었고 무엇보다도 논문을 많이 쓰시는 분입니다. 순환기계, 신경과를 담당하시고 Photomedicine and Laser Surgery 저널의 편집위원이십니다. 이번 한국의 전화진료단이 사용한 진료 권고안을 만드는 데 큰 기여를 하셨습니다. 발표의 제목은 Clinical Guidance on COVID-19 in Korean Medicine and the Role of the Telemedicine Center입니다.
Hello, my name is INSOO Jang and I am a professor affiliated with Woosuk University. My talk will be on the clinical practice guidelines on COVID-19 in Korean medicine and the role of the telemedicine center. I was the chair of the CPG Development Committee on the Korean medicine treatment for COVID-19, and I also was on the advisory board for the Telemedicine Center of Korean Medicine for COVID-19. In March, at the TCI online seminar, which is under the WHO, the World Health Organization, I conducted a talk on Korean medicine use, and there were 10 different talks, and I mainly talked about the role of Korean medicine for COVID-19 in Korea. I also submitted a letter titled How Telemedicine Can Ease Hospital Workloads Amid COVID-19 for newspaper coverage in the South China Morning Post, which is published in Hong Kong. I will review the current state of COVID-19 currently globally, and as of 27th of November, there are currently 61 million confirmed cases, and there are over 1.4 million deaths. And by very crude estimates, it is estimated that we will reach 100 million confirmed cases in about 3 months. And in that case, COVID-19 would become the pandemic that ranks third in total confirmed cases and deaths. The first would be the pest of medieval times, and the second would be the Spanish flu of 1919, and the third would be COVID-19. The fatality rate is currently estimated at 2.35% worldwide. The three highest ranking countries are the US, India, and Brazil, and these three countries take up 40% of all cases. And it can be considered a considerably high spread and a tragedy for the whole world. Next, the other country rankings are listed, and you can see in Mexico the fatality rate is high at almost 10%, and so there is quite a great discrepancy regarding the fatality rate between nations from about 1% to almost 10%. Low fertility rates are shown in Austria, Japan, and Taiwan, and South Korea is currently ranked at 93. However, currently we are facing the third resurgence, and so constant vigilance is required of all of us. So the current state for Korea overall has been addressed, and regarding the regions, currently the Seoul capital region and also the Gyeonggi ji역 and the Incheon ji역 show highest occurrence. In March, when we had the first mass occurrence and outbreak of COVID-19, the Daegu and the Gyeongbu region was where we had the highest number of occurrences and confirmed cases. However, presently, the Seoul and the Gyeongin region is where we show the highest increase in number of patients, and the spread is also fastest. These contents were also introduced in my talk in the WHO talk, and Korea was very swift in its response and also in acquiring test kits. And so large-scale diagnostic tests were conducted every day with 20,000 cases tests conducted every day. And also regarding disclosure of movements of the patients, they are identified immediately using smartphone location services and also credit card use monitoring. And we have transparent information disclosure and also utilization of various innovative technology such as drive-through tests. And we are also spreading them overseas for global use. And Korea also acted faster than any other country regarding the classification of patients according to their severity. And so patients who were asymptomatic or mild were secluded in life care facilities, and those who were moderate and severe and required immediate medical attention were allocated to hospitals and ICUs. So the dispersion of patients was received global attention regarding its effectiveness, and we still are considered to stay safe, relatively safe, stable, and have orderly control. Last July, we had an online conference between the Society of Korean Medicine and the Chinese Medical Academic Society. And here, Tong Xiaoling, who is known as one of the leading experts in traditional Chinese medicine regarding COVID-19, gave a lecture. In China, COVID-19 is considered to be a 한스벽, which is a cold and dampness pandemic. And so it diverges slightly from previous warm infectious diseases. This is a map showing Wuhan of China, and you can see it is somewhat similar to Florida. There are a lot of water regions, swamps, lakes, and the relative humidity is always over 80% all year round. And so this gives rise to the reason why a pandemic such as COVID-19 occurred with a cold dampness pandemic. In Korea, starting in February and March of this year, we provided telemedicine services for Korean medicine and COVID-19 using non-face-to-face consultations. And the strengths and limitations, pros and cons of these services are very distinct. Regarding the cons and limitations, the largest limitation is that we only provided care for mild cases, and also the herbal medicine prescriptions were limited. Also, treatment was limited to non-face-to-face care, and the government cooperation and support was limited and restricted. The pros and strengths of Korean medicine use in COVID-19 was evidenced in the March WHO conference, where China and Korea were the only countries that were able to provide traditional medicine treatment to early confirmed cases. And also, Korean medicine showed a very rapid response to treatment. And through this, we were able to provide Korean medicine treatment to about 20% of all confirmed cases in Korea. And also the reports of Korean cases based on theory and the case reports data are being accumulated to be published in various research outlets. And therefore, they show the potential for use of Korean medicine in COVID-19 and other pandemics. Next, I will give an introduction of the CPG for Korean medicine for COVID-19 use. Although in English we use the term CPG to refer to these kind of guidelines, this does not apply to infectious diseases, as there is not enough time to develop them according to the normal format, and we have to be dependent on expert opinion. As they cannot be developed according to the regular format, we have to use mainly expert consensus, and so in English the term guidance is more appropriate. The Korean medicine version also uses the term Korean medicine recommendations instead of CPG, and this is for similar reasons. The first Korean medicine, Korean edition, was prepared in March, and the indications for Korean medicine treatment in COVID-19 were limited to mild patients and patients in the recovery stage. Although this could be viewed as a limitation, it also reflects the situation in Korea, and in moderate and severe stage patients, conventional Western medication and interventions were used as the main modality, and herbal medicines and Korean medicine was used in conjunction. As Korean medicine's approach to COVID-19 confirmed cases was limited, this was why treatment was mainly limited to the mild and recovery stage patients. The overall order of contents are as follows. The image that you see here is the algorithm flowchart in the Korean medicine guide for coronavirus. When a patient confirmed as COVID-19 comes in, the algorithm is divided within the flowchart based on diagnosis of pneumonia. Division is also dependent on respiratory symptoms and general symptoms. On the far left, we have asymptomatic patients, and next, early mild stage, mid-mild stage, moderate and severe stage, and we have, lastly, the critical stage, with critically ill patients. A simplified flowchart is shown on the screen here. When COVID-19 patients first come in after confirmation, they are divided according to diagnosis of pneumonia. Further, based on whether they have fever or not, they are classified as heat syndrome. Various non-respiratory symptoms are also accompanied in many COVID-19 patients. The most frequently seen symptoms are diarrhea and severe fatigue. These patients are classified as dampness syndrome. These contents are reflected in this table. The classifications and prescription recommendations are connected with the relevant symptoms. The general prescription is shown on the far right and is 청패배독탕 and can be used in all stages. In the early mild stage, patients are divided into external heat syndrome according to fever and dampness syndrome according to diarrhea symptoms. And in the mid-mild stage, it is divided into internal heat syndrome and severe dampness syndrome. And then treatment is divided into the moderate and severe stage and critical stage. In English, this shows the overall table. In the early mild stage, we have external heat syndrome, and here the main symptoms are fever. And for prescriptions, we use 형방회독산 and 구미강알탕. In dampness syndrome with complaints of diarrhea and loose stool, 곽향전기산 and 곽반 할영탕 are prescribed. In the mid-mild stage, we have internal heat syndrome where the heat symptoms become more aggravated, and we also have the severe dampness syndrome. Prescriptions are used according to the pattern differentiation patterns differently. Various prescriptions are given, including 마인감석탕, variations, and 응교산. In the moderate and severe stage, similarly, 마인감석탕 variations are used according to stage. The reason why we propose 청패배독탕 as a general prescription is that although herbal medications indicated for antiviral diseases and influenza were already presented, and these various prescriptions are included in the Korean Medicine Guide for Coronavirus Disease. However, there are no prescriptions that have been confirmed to be corona-specific. At this time, the only prescription was that from China that was investigated and confirmed to have effect in coronavirus patients. Data was collected from patients, and so we used 청패배독탕 as the basic prescription. Also, one of the main characteristics for Korean medicine use was that it was conducted non-face-to-face. The reason for this was that face-to-face consultation was not available. Is the only reason for this. Because the patients were under a self-quarantine or self-isolation state, there was no choice as no contact between the patient and physician was possible. And regarding this, pros include the fact that it was safe for both ends, both the patients and for the physician. And also, self-vital checks and various self-reported data was collected by various methods in an attempt to collect data exchange, including body temperature, respiratory rate, and heart pulse. The fact that information was exchanged and questions and answers were given in non-face-to-face format were some of the strengths of this format. And the cons and limitations include the fact that it was difficult to diagnose. Diagnosis was highly limited, and also it would take more time, and the inaccuracy was higher. Despite these limitations, the indicated patients were in the mild and recovery stage, and some characteristics including the fact that the treatment was free and complementary and all expenses were covered by donations can be considered to be some major strengths. And Korean medicine was thus conducted without a further burden on the patients. As shown on the screen, various centers were established and operated. Self-check of respiratory rate and heart rates was also optimized, and we also made use of EMR records and various smartphone applications, and KakaoTalk and FaceTalk, which are widely used in Korea, were also some main communication tools and some strengths of our telemedicine center operation. This is an analysis made on July 10th regarding the results of our telemedicine center operation. And we saw that over 21% of all COVID-19 patients in Korea had received our telemedicine services. This was a first effort and a trial for us in this type of consultation operation, and we believe that it holds great implications for primary healthcare. The reason for this is from two different perspectives. The first is regarding whether we would prefer to use single-use level D personal protective equipment, including goggles and the gowns, and still be exposed to various risks, or use telemedicine in non-face-to-face consultation and treatment within possible boundaries. And so within primary healthcare, regarding which option is more appropriate is something that we should consider. I will briefly cover primary healthcare providers in Korea. Regarding the average rate of primary care physicians, according to the OECD, the average is 28.9%, and in Korea, including Korean medicine doctors, it's estimated at 27%. And so a little under 30% of physicians are designated as primary care physicians. However, 80% of COVID-19 patients are mild stage patients, and also the pandemic is currently underway and ongoing. And so the government needs to think of how to utilize their resources of primary care physicians, including Korean medicine doctors, better in response. And we believe that this will provide a better solution to COVID-19. As a last message, I will sum up my lecture. We are still currently evolving and underway, and the third wave of COVID-19 is currently occurring within Korea. And we are currently unsure as to how the situation will evolve from here. However, the Korean medicine doctors, the services they provided in non-face-to-face services, although it might be the second best, it could be a different alternative solution. Although it might not be the best, still as the second best, it still holds great implications and potential. As in acute infectious disasters and pandemics, it may be the last option and most optimal in primary care. And policy providers and the government should be very mindful of these facts. How primary care physicians are utilized should be given further consideration and review. Thank you.